ASL 1
Are
and
we
how to
ready?
take ASL 2.
I think I have my life together if we're ready. Okay. No news is good news. So we'll go ahead and get started. So I'm going to try to section this lecture off in 3 different little sections. So we'll do a 5-minute break in between the first and second, and then the second and third section, just because I feel like it makes sense in my brain. And I know everyone's probably very overwhelmed with cardiac. Don't be. I'm not trying to turn you into a PCV ICU nurse. This is literally a specialty within a specialty. So please don't be panicking. I really just want you to understand the concepts, what your patient's going to look like, the basic things to do. Like I said, specialty within a specialty. I'm not going to ask you what is the second stage of this surgical procedure, et cetera, et cetera. That's not fair. So please, if that allays some anxiety, please let it allay some anxiety. So let's get started. So here's our objectives. These are from the book. Here's our concept highlight. Okay, so as usual, we'll start with some peds. Probably need to get back on the table and fix it. Sorry, guys, if you want to. Y'all on the other campuses don't mind truly getting on the table. He's gonna fix our projector. We had some HDMI issues. Perfect. Thank you, sir. Okay, don't fall. Okay, so some differences here, 2 big ones with cardiac, which we've kind of already talked about this a little bit when we talked about ER and trauma. So remember, cardiac output equals heart rate times stroke volume. So cardiac output is literally the volume of blood that's ejected from the left ventricle each minute. So this equates to the blood that's circulating to the body, correct? So stroke volume is the amount of blood that's ejected with each heartbeat. Now, remember, we talked about stroke volume is relatively fixed in pediatric patients, especially our infants and our littles. They don't have the ability to stretch those rubber band heart muscles to elongate them, to increase that stroke volume, to increase their cardiac output. So really all they can do, remember like we said, is marginally increase their heart rate. But remember as well, our littles, just peds in general, but then especially the smaller the patient that you're dealing with, they already function at a pretty high heart rate, right? Because their metabolic rate is just all jacked up on Mountain Dew. So again, that translates to they don't have a whole lot of wiggle room whenever they start to become stressed out cardiac wise. And also remember, so this means they're very heart rate dependent on their cardiac output. But again, not a whole lot of wiggle room. And the higher our heart rate is, that also decreases the time for the ventricles to fill, right? Beating faster, but we don't have as much time to relax during diastole. So that's kind of going to be a catch-22. And so it's only marginally effective in increasing our cardiac output. We talked about the relative inability to increase that stroke volume, so less contractility there. And then their ventricles are less compliant. So again, kind of goes back to the same, less ability to stretch that heart wall and increase that cardiac output. So what does this mean, Ms. Schinber? Why does this matter to me? Basically, the smaller your pediatric patients in general, but especially the smaller your pediatric patient, they're going to develop heart failure very quickly. So we don't have a whole lot of time when we're going to talk a lot about congenital heart defects. Today, we don't have a whole lot of time if we don't detect those early. If that baby gets sent home, not uncommon at all for them to come back 2-3 weeks within that first month of life in fulminant heart failure. Because they just don't have any of the reserve. They don't have the compensatory mechanisms like you and I do. So very, very important for us to identify any issues and address them as quickly as possible. Preload, and this should just be some review of terminology here, review of patho. Preload is the volume of blood that is in the ventricles at the end of diastole. So think of this as what fills the pipes. This is what's returning to the heart. So think about that dehydrated patient. Their preload is decreased, right? They don't have as much volume returning to their heart. So this, therefore, is going to in turn result in less cardiac output, because if we have less volume returning to the heart, that translates to less blood that the left side of the heart is then able to eject to the body, right? Hanging with me? So then afterload is the diameter of the pipes. So think resistance that the ventricles have to pump against to eject blood out of themselves. So think about hypertension. It's harder for the right ventricle. We're going to talk about a little bit about pulmonary artery hypertension as well, and you'll go over that in much more detail in fourth level, but that's a big thing with congenital heart defects, pulmonary artery hypertension. It makes the right ventricle have to work that much harder to eject blood, just like systemic hypertension makes the left ventricle have to work that much harder to pump blood out of it, right? So this can almost also limit total cardiac output, because that right ventricular stroke volume, or the volume of blood being ejected from the right ventricle, is going to translate to the amount of blood that should be returning to the left side of the heart in the left atrium, right? And then blood goes left atrium, left ventricle, then left ventricle out to the rest of the body. So it's all kind of connected. So basically, if we have a hiccup in either one, it's going to affect the other negatively. And then contractility is just the strength of contraction and relaxation. And we do see decreased contractility in certain disease processes, like heart failure, cardiomyopathy, which we'll talk about as well. So our second difference is total blood volume. So you don't have to memorize this number, but just to put it into perspective, pediatric patients have anywhere between 70 to 100 mils per kilo of blood, compared to about 5 liters total in adults. So if you math it out, it's pretty similar in mils per kilo, but remember that basal metabolic rate is much higher in kids. So what does that translate to? They're not going to tolerate blood losses like you and I will. So again, just a lot less reserve. They don't have those compensatory mechanisms like you and I do, and they're going to become stressed out a whole lot quicker. I tried to put a GIF or a GIF, I don't know the correct pronunciation, of a fainting goat, just because they're very dramatic, but I couldn't figure out how to get it in there. So you just have the cute little picture of the little girl being dizzy and dramatic to help you remember. And so I'm very visual. I'm sure you've learned that about me by now. So if you did somebody need something? Oh, okay, sorry. I'm very visual, so I love all the pictures. This is a 55 slide PowerPoint, which is unusual for me, but a lot of it's pictures, so don't freak out. I've used these all the time when I was in school, so I just find that they help. Hopefully they help you as well. So assessment, this is a little box straight out of your book. We're going to go through a lot of these signs and symptoms as we go through the different disease processes, but I did want to reference it here, and it's table 22.2, and then box 22.1 in your book goes over just the different like abnormal health assessment data, head-to-toe assessment data that you might see in a lot of these conditions. All right, intervention. So normally I don't lecture on this section, but I'm going to this time just because I feel like it's not all fundamentals. And this is kind of a different, I know you guys have gotten some cardiac before in second level, you'll get a whole lot more in fourth level, but we'll go ahead and go through all of this. So this is page 373 to 378 in your book. Box 22.1 has a lot of information about lab tests and diagnostic procedures. Be sure to review that. It should all be review. I'm sure you guys have gone over like heart caths and stuff like that before. We'll talk about it some here. But a lot of those labs should be reviewed, right? Like BNP, brain natriuretic peptide, troponin. It's got a lot about electrolytes, things like that. So first intervention, maintain oxygenation. So cardiac and pulmonary work very closely together, right? If we see one be stressed out, odds are the other is going to follow suit. And we're going to talk a lot about oxygenation and cyanosis and oxygenated versus deoxygenation and shunting and stuff today. So one of our big interventions is going to be administering oxygen to our patient. So supplemental oxygenation if we need to. And then all those airway patency things that we talked about previously. So suctioning, positioning. What position do you think you'd want to put a patient that's in cardiac distress in?
IFL?
Yeah, probably, sitting up, right? We definitely don't want to put them laying flat. They're not going to love that. Very astute assessment of cardiorespiratory status. And we also want to know what their normal saturation is, oxygen saturation. These are situations that we might be okay with a kid's oxygen saturation being in the 70s to 80s. With certain ones of these congenital heart defects, they're just not going to do any better than that because of the way the blood is shunting. And so it's very important to know what's this patient's normal saturation. So that way you're not, having a sphincter tightening situation with a sat of 84 when that's great for this patient because they have a defect, right? We want to assess for and report signs and symptoms of cardiac distress and then also respiratory distress. We'll talk later about interventions for TET spells. Those are going to be pretty big. All right, cardiac output and tissue perfusion. So again, we're monitoring heart rate, blood pressure, cardiac rhythm. It's going to be very big with these kiddos because they're on all kinds of diuretics and meds, and ACE inhibitors are pretty big with these kiddos. They might be fluid volume overloaded. Their, ventricles might be hypertrophied or stretched out. Their atria might be stretched out. And you'll find anytime the cardiac muscle is stretched or anatomically not the way that it's supposed to be, the electrical conductivity doesn't function the way that it's supposed to either. So we see a high incidence of arrhythmias in these patients. Capillary refill time, pulses. A lot of these kiddos will be on digoxin. So pull all that up from pharm. I'm going to have a cutesy little picture on the next slide about that.
So they'll see like the halos and stuff too.
Right, but it's going to be harder. So the question was, so they'll see the halos and stuff. Yes, all the same signs of toxicity will be there, but
They may not.
could be in a nonverbal toddler.
Right.
So therein lies, like extra level unlocked, right? Like bonus level unlocked have to try to determine, is this just a toddler being fussy or are they nauseated? Are they busy? Are they, maybe seeing, the yellow, the halos, they just can't quite verbalize that to me yet. Promoting rest will be very big. These kiddos don't have a lot of reserve at all. Monitoring electrolytes and replacing them as needed. A lot of these kiddos will be on like oral electrolyte supplementation just because, like I said, everybody's on furosemide. Be losing, losing electrolytes, retaining electrolytes. So frequent lab monitoring will be important. And then when we talk about surgical procedures, these kiddos are going to go to CVICU, ped CVICU after surgery. These are massive surgeries. And so this is a critical care patient. If we're talking, post-surgery, they've got, probably bilateral chest tubes, if not bilateral and a mediastinal chest tube. They're intubated on all the drips, all the things. On pressors, just very, very complex patient. Maintaining hydration and nutrition. So these kiddos could be hypervolemic or hypovolemic. A lot of times with, cardiac, we're worrying about fluid retention, right? So that could make us be relatively hypervolemic. But in some of the infectious conditions that we'll talk about, they might present as dehydrated. So we want to monitor strict I's and O's. What's the best way to determine if a patient has gained or lost weight?
Daily
Daily weights. Monitor for edema. Might also measure some abdominal girth, just because as we talk about heart failure, right-sided heart failure, blood's going to back up into systemic venous circulation, right? So we can have some swelling of the spleen, swelling of the liver, and so that can make our abdomen get larger, right? And then also just third spacing. They can hold on to that fluid in their belly as well. Typically with these kiddos, we see a very high metabolic demand. So think even more so than what we already were as a pediatric patient. This child's, if we're talking about heart defects or, these infectious conditions, even greater metabolic demand because their body is having to work overtime to circulate a lesser amount of oxygen than what it normally would be able to do at baseline, especially as we start talking about these defects where blood is being shunted left to right or right to left. So their body is having to work overtime. So this increases the metabolic demand even further. And then a lot of times we see decreased intake with these kiddos with the heart defects because they get very tired when they eat. Especially if they're being stressed out respiratory-wise from pulmonary overcirculation, which we'll talk about with the first round of defects. It's a lot of work for a baby to suck from a bottle to begin with. But then when you throw in the fact that their heart is beating close to 200 times a minute trying to circulate oxygen, and their lungs are kind of fluid overloaded because half of their blood volume is being recirculated with pretty much every heartbeat back to their lungs, it gets to be a very cumbersome task for them to eat enough and eat effectively. So they'll get very tired during feeding. They're not going to complete their feedings. And it also, sweating during feeding is a very big telltale sign of cardiac distress. And if you think about that, it makes sense because this patient's body basically goes into fight or flight mode, right? The sympathetic nervous system is going to be stimulated because oxygen levels are low, cardiac output could be low. So that triggers all of the innate mechanisms in our body to release all of those stress hormones. So epinephrine, norepinephrine, all of those things, which really makes the situation worse, right? Because that vasoconstricts, that makes the heart beat faster, which only stresses the situation out more. But that's why you'll see that diaphoresis or the sweating when they're eating, because their body is very stressed out. And it's those stress hormones that are being released. So we will see a dietitian consulted pretty frequently. With older kiddos, we want to offer their favorite foods. We're going to do, small, frequent meals. Babies, a lot of the times, if they just cannot tolerate oral feedings, we'll do tube feedings. Or they might have a peg tube if it's going to be a long-term ordeal. Probably have them on a low sodium diet, like the sweet little elderly people with the heart conditions. And we want to do high calorie stuff whenever they do eat. So this will be an instance where babies will be on high calorie formula, basically so we can get them more bang for their buck, right? Because we still have to get the same number of calories, like their body still needs the same number of calories, if not more than they would at baseline. But with formula, more calories means more volume, right? Are we going to tolerate more volume? Nope, they're already not completing their feedings to begin with. So in this situation, we can add additional calories. We can give them high calorie formula so they get more calorie bang for their volume buck. Promoting pain relief, comfort, and rest is going to be very important. We want everything to be a low stress situation because that decreases their metabolic demand and therefore their hemodynamic stress. So we definitely want to treat pain and fever promptly and appropriately. Lots of naps. Love naps. This will be a situation where we don't necessarily cluster care. I know that's something that we've taught you a lot of the times is a good thing to do. Get in, do all the things you need to do, and then get out, right? Do you think a cardiac patient's going to tolerate that very well? For you to be in their bed doing intense things to them for all at once for 30 minutes? No, you're going to stress them out. So, prioritization of what do I need to do right now? Or, what can I come back in a little while and do later? How can I, still take adequate care of this patient, but kind of space my care out appropriately so that I don't stress them out hemodynamically. And then, of course, age-appropriate, low-energy, developmentally appropriate activities. At the end of the day, this is still a kid that has developmental tasks to meet. This is still a baby that, we want to still learn to roll over and sit up and do all of the baby things. Meds. And these will be all throughout the chapter. Like I said, ACE inhibitors, common. Aldosterone receptor blockers, common. Digoxin. We'll talk about beloved IVIG again a little bit. Antibiotics. When we talk about bacterial endocarditis, treatment of it, prevention of it with all of these defects. We'll talk about 2 big no-nos. I love this lecture because I feel like we harp on you all term. No aspirin, no NSAIDs. And I'm going to tell you to give both today. But these are situations where the benefit outweighs the risk. So we will talk about aspirin, NSAIDs. So of course, we're checking for appropriate doses, monitoring for therapeutic effect, monitoring for side effects. Monitoring for and preventing complications. We'll talk about heart caths on the next slide, but that's going to be a lot of what we're talking about in that little bullet point. Because heart caths are very, very common, done very frequently with these kiddos. Growth and development, we talked about that. Lots of hospitalizations, not uncommon for, especially a critical defect, for them to spend upwards of a lot of their first year of life in the hospital, unfortunately. So we want to promote normalcy as much as possible. Child Life is a wonderful resource for that. OT, PT, and then as always, emotional and psychosocial support for the kiddo and the parent. This is a huge life-changing condition a lot of the times. All right, as promised, review your dig stuff. Big difference here is our heart rate that we hold it at is going to change. So in older kids, it'll be 70. Infants, more like 90. All right, heart cath. Do you guys go for heart caths in second level? No? Okay. Very little? Okay. So basically, a cardiac catheterization is where it is a procedure. It's a kind of pretty much a surgical procedure, very invasive. They can go in and access the right side of the heart through a vein. So basically, a lot of times in adults, they'll use the femoral veins, other, maybe subclavian with a kiddo, but they can, basically thread a catheter and a device through all the way, up through the vein to gain access to the right side of the heart. They can take biopsies. They can, do cardiac ablations if we're having arrhythmia problems where they literally, destroy a part of the heart muscle that's doing crazy electric conductivity things. They can go in and open up, valves if they're sticking together. They can create openings where there isn't one. They can close openings where there are one and they shouldn't be. They can estimate pressures, they can estimate oxygen saturations, they can do all kinds of very, very cool invasive things during a heart cath. And they can do the same for the left side of the heart, they just have to gain access through an artery. So just, kind of preamble there to kind of explain to you. This is going to be a very big intervention, very common intervention that's going to be used with all heart patients, but especially these kiddos. So pre-procedure, we want to make sure they're NPO as appropriate. And advocate for some kind of dextrose IV fluids to be on board. Because remember, our kiddos do not have that glycogen reserve. They don't have the same fat stores that we do. They'll get hypoglycemic a lot quicker. We can witness consent. Make sure that's signed. And we'll want to collaborate with the providers to see what meds we want to hold, which ones we want to go ahead and give. That can change kind of, case by case basis. Infection. So with this, we're talking about post-procedure with the access site. This is a big safety thing. So we want to keep the dressing dry, change it per orders. Typically, they'll say no tub bathing for, a certain amount of time, and we'll collaborate with the doctor on that. We want to assess the site for signs and symptoms of infection or inflammation. And then, of course, what vital sign do we want to monitor?
Blood pressure.
I guess all of them. But we're thinking specifically infection.
Oh, fever.
Fever. Monitor for fever, right? But yes, white blood cell count as well. So bleeding is a very major complication during the procedure, but we don't have a whole lot of control with that. That's the surgeon. But after, so you can see this picture at the bottom is a pressure device. So that's a hip bone, and you can see like the femur. And so it's got this little balloon, almost think like a Foley, the balloon that you blow up at the end of a Foley. So, you can inflate that balloon, and it keeps pressure on that access site, because this is a major vein or a major artery that they've gained access to, right? So this is a really, really big bleeding risk. So typically they have to maintain 4 to 6 hours strict bed rest. So good luck with that with a toddler, right? Typically they'll hold about 15 minutes manual pressure, and then place some kind of pressure dressing or a pressure, maintaining device on that site. But we want to assess it, very frequently. Because if we start, seeing oozing or anything like that, that's going to be very much an emergent situation. We want to call that provider, call that provider back. So again, along with that, what to do if bleeding occurs. So do we leave the patient?
No.
No. What do you think you're going to want to do?
Hold pressure.
Hold pressure, press the call button, right? Like panic button. Have somebody, you stay with the patient, hold pressure. Definitely get somebody else there with you to call for help, and then they can get the provider back down and, better determine what intervention needs to, go on from there. Whether, we give medications or we need to go back, and fix something or whatever it may be. But don't leave the patient. Definitely hold pressure. We want to monitor for hematomas and clots as well. So even if we don't necessarily see external signs of bleeding, something that can happen when you gain access to a really large vessel like that is a hematoma or a bruise, right? That's just a fancy nursey word for bruise. Can develop underneath the skin. And this might not be readily apparent to you outside. Your dressing might not necessarily be saturated, but you're going to see signs like that tissue might become kind of purple and swollen, right? And we also worry about clots forming because that's part of the body's protective mechanism, right? An artery, a vein gets punctured. The body starts all the things to try to clot that off so that you don't bleed to death. Thank you. But if we've got too big of a clot that forms there, maybe our platelet counts are extremely elevated, or we've got an inflammatory process going on. If we've got a major clot that forms, what then cannot continue to go through that vein or artery? Blood flow. So then we've got like a neurovascular compromise situation going on, right? So neurovascular checks distal to that access site are going to be very important. We want to monitor for arrhythmias. This kiddo will likely come back, on continuous cardiac respiratory monitoring. They need, to remain on cardiac respiratory monitoring. Cardiac muscle is very much a touch me not, kind of like the airway. Heart muscle doesn't like to be fiddled with. So we've got somebody that, basically shoved a catheter all the way up in their heart and was poking and prodding around in there. We can see some transient arrhythmias afterwards, okay? This is a situation where they will likely, for different tests and visualizing different things, administer contrast. So what are my big worries with that? Allergies, and then what organs am I worried about? Kidneys. So BUN and creatinine at baseline, and then probably trend that afterwards. And then I want to make sure that they're doing what adequately?
Morning.
Make sure those kidneys didn't take a hit. Because in light of the fact that we've probably got some heart failure, kidneys might not be being amazingly perfused to begin with because we've got some kind of defect. Might not already be in a great kidney situation, right? So let's not add insult to injury. And then education. Sometimes this is done as an outpatient procedure, or, it'll be done and then they go home the next day. So we want to make sure that caregivers are aware of all of these things. And then here's a picture from the cath lab. So you can see it is surgery. Everything's very sterile. You can literally see someone's heart. That dark, skinny thing is the catheter that they've got literally in someone's heart. Pretty cool. Pretty amazing. Kind of scary. All right. Heart failure, sad face. So a lot of this should be review. I know you guys laid the foundation, went over heart failure in second level. It's going to be all very, very similar with kids. Heart failure looks like heart failure. So our etiology are our cause here. There are many causes. The number one most frequent cause in kids is going to be congenital heart defects. But whatever the cause is, we've got some kind of structural or functional impairment of the ventricles. So like we said, congenital heart defects, drugs, illicit drugs can cause heart failure. Chemo, it's very difficult on the heart. Widespread inflammation or very severe inflammation, so your patients with autoimmune conditions. Arrhythmias, chronic kidney disease. They're typically fluid volume overloaded, right? And then also all those compensatory mechanisms, the renin-aldosterone angiotensin system gets activated. Lung disease. So you'll find and you'll learn and hopefully better understand after this lecture that the vasculature, I want you to think of the vasculature within the lungs and the heart as being connected, because they essentially are, right? Like all vessels are connected some way, somehow. So if we've got a pulmonary situation that results in what we call increased pulmonary vascular resistance. So basically the vasculature within the lungs is very constricted, very tight, very difficult to perfuse. That causes increased back pressure, right, on the right side of the heart. So pulmonary conditions can cause right-sided heart failure. That's literally called cor pulmonale. Very, very common. That's a big worry because once that starts occurring and we start to develop pulmonary hypertension, frequently our interventions are not very effective. So then at that point, we're looking at needing a transplant, which doesn't always happen. So patho here, we've got increased preload. So fluid volume overload and or increased afterload. So regardless of the cause, whether it's one or the other or both, cardiac output starts to fall, which means perfusion is no longer adequate. Oxygenation is also going to fall. That RAS system is activated. So think back. The second level, think back to patho. RAS makes aldosterone. Aldosterone causes sodium and water retention. Angiotensinogen is converted to angiotensin 1 and then angiotensin 2, which is vasoconstrictor, and all these things that put stress on an already stressed out heart. So in a way, it kind of augments our preload and afterload, right? But it just becomes this vicious cycle where our compensatory mechanisms just stress our already stressed out heart further until eventually the heart's unable to meet the metabolic demand of the body and the patient will start to decompensate. Hopefully we catch them before that. But unfortunately, that's not always the case. Table 22.6 has your clinical manifestations. I've got 2 slides after these that kind of delineate right-sided versus left-sided heart failure. And we'll go over that as we get to them. But typically, left-sided heart failure is pulmonary symptoms, right? Because fluid is backing, or blood is backing up into the pulmonary system, which makes our lungs very wet and stressed. Whereas right-sided heart failure, we typically see edema and systemic venous congestion and jugular venous distension and hepatomegaly and splenomegaly and all of those wonderful terms that I know you just 100% remember from second level. All right, lab studies. A lot of these should be review again. Box 22.7 in your book has them. So BNP is high or low with heart stuff. So brain natriuretic peptide. High, right? BNP is the body's innate mechanism to try to diurese itself. So the higher the BNP, the more stressed out your heart is. Troponin, probably be high, right? Heart stressed. Might be anemic. Do you think it would be true anemia? Probably not. What kind of anemia do you think it would be? Or fluid volume overloaded.
Just like
You're watered down.
Dilutional anemia. Probably just dilutional anemia. And then also if the kidneys are not working great, remember kidneys produce erythropoietin, right? If we got some kidney injury there, you might have a little touch of actual anemia as well. Low sodium levels, again, dilutional, right? Or fluid volume overloaded. AST, ALT elevated. Liver is stressed, not being perfused adequately. And same thing with kidney labs. Some other diagnostic stuff we can do, chest x-rays, echoes, a special MRI called a cardiac MRI. Might get EKGs, especially if we're looking at electrolyte issues, and then heart cath, like we talked about. So intervention-wise, all the things we talked about on that nursing intervention slide, right? All those things hold true. Meds, the pharmacy 22.2 goes over heart failure meds, but again, diuretics, DIDG, ACE inhibitors, probably beta blockers. Try to get the heart to calm down, not stress out so much. They need all their vaccines. Because remember, any respiratory pathology is going to hit them 500% harder than the average bear. So pneumococcal vaccine, will probably qualify for that one. Flu, RSV, COVID, question mark. So in addition to that, medical management, kind of surgery wise, if medical management has failed, might be looking at, a ventricular assist device. So a right ventricular assist device or a left ventricular assist device. Typically that's a bridge to transplant. We don't love to do that because they have to live in the hospital, but better than dying. But ultimately might need a transplant. We want to educate on signs and symptoms of worsening condition, whether right-sided versus left-sided, and then absolutely any of these conditions. It's, I would say, imperative. It's a great idea for caregivers to be CPR certified. Cannot tell you how many times I've seen a kid's life be saved, especially with like weird congenital stuff that you don't know that they have it till they literally go into sudden cardiac arrest. And it just so happened, the parent was a nurse practitioner or something like that, and they knew CPR and they saved their kid's life.
Good question.
Yeah.
So I know you said assisted devices. Do they do LVADs in kids?
They're just little.
Do they have to still be in the hospital for
Yep.
them?
As I'm saying, it's not ideal to live in the hospital most of the time, but it's better than alternative.
Yeah, sure.
Like I said, typically that's a bridge to transplant. Pediatric hearts are not, super easy to come by. So you'll see I've linked YouTube videos. There are these osmosis videos, like the producer, I guess you'll say, is Osmosis by Elsevier. I love those little videos. They're really great. I find that they put things in very easy to understand terminology, and they're very like pictorial and visual. So I've linked them on all the slides for all the different things if you're visual and you find that they help. So that's what that is. Okay, so left-sided heart failure should just be a review, right? So left-sided heart failure, left ventricle is not participating in real life as much as it should. So blood is backing up to the lungs. It's not moving forward to the systemic circulation. It's backing up into the lungs. So you'll have that paroxysmal nocturnal dyspnea where they wake up in the middle of the night and they can't breathe when they're lying flat. They have to sit up. Elevated lung pressures. You'll learn more about capillary wedge pressure and cord bubble. I won't get in that right now. But signs of pulmonary congestion. So cough, a very wet cough. Very wet lung sounds, crackles or rails, wheezing. They might have some, blood-tinged sputum that they're coughing up, some lovely pulmonary edema. And then tachypnic. Especially tachypnic for no good reason. Like that's a big sign, and we'll talk about that with congenital heart defects. A lot, if you've got a kid that's tachypnic for no good reason, think heart. If there's no pulmonary pathology evident that they're tachypnic, think heart. So then you're also going to have signs of low cardiac output to the systemic circulation, right? So restless, they're very air hungry, they're oxygen hungry, their body is not being oxygenated and perfused. They're confused because their brain's not getting enough oxygen. Orthopnea, we talked about that. Tachycardia, heart's trying to compensate, right? Body saying, hey, all these chemoreceptors throughout the body are saying, hey, I'm kind of acidotic, I'm hypoxemic. Can you please give us more blood flow? Can you please give us more oxygen? So the heart vamps up the rate as much as it can. Exertional dyspnea, fatigue, cyanosis. So that's more so left-sided. Right-sided. So with this, remember, right ventricle not participating as much as it should be. Blood is not going forward to the lungs, but is instead backing up right ventricle to right atria, then back into superior and inferior vena cava, the systemic venous circulation. So again, fatigue, because we're not getting a whole lot of blood moving forward. Increased peripheral venous pressure. So we'll see that ascites. We see that hepatosplenomegaly. We see the dependent edema, the weight gain, the 1 pound overnight That's not Chick-fil-A. Maybe the salt from the Chick-fil-A, but we see the JVD, the anorexia, the complaints of GI distress because they feel pregnant, right? They got all the fluid in their belly. And again, remember we talked about right-sided heart failure can be secondary to chronic pulmonary problems. In your adults, that's typically COPD. We don't have COPD in kids. Our equivalent to that is kind of like BPD, which is bronchopulmonary dysplasia, very common in NICU babies, but again, caused from pulmonary damage that then exerts an enormous amount of back pressure on the right side of the heart and causes the right side of the heart to fail. So just another cutesy. These are things we've talked about, but I love little mnemonic devices. And then another little cutesy visual just with the interventions that we kind of talked about. So unload fast. Really everything applies in Peds except nitrates. And we'll give nitrates sometimes, just not so much in this situation. All right. How am I doing on time? All right. Do we need a 5-minute break or are we okay? If we need a break on other campuses, it's okay. I guess no news is good. Okay. Right. Speak now, forever hold your peace. All right. So congenital heart defects are congenital.
No break requested from Alec.
We're good? Okay. So congenital heart disease. So this, we're going to be talking about the congenital defects. So I'm kind of going to give a general overview, and then we'll go through some of the specific defects. I've got asterisks by the ones that are more common. Some of these are pretty rare. And again, this is a specialty within a specialty. So I want to expose you to it. I'm not none of us are 1,000,000% sure what the Lippincott exam is going to ask you. But I don't super feel like the NCLEX is going to ask you about something that is, like 1 in 10,000 instance. So I will expose you to it, but I really want you to focus more on the ones that I've got an asterisk by. Okay, those are going to be your much more common ones that you'll see. So, CHD occurs in about 8 of every 1,000 live births. So you guys haven't had OB yet, but you'll learn embryologically, the fetal heart develops very early in gestation. All of the organogenesis occurs in the first trimester. Unless you are trying to get pregnant, it's not uncommon for somebody to not realize they're pregnant close to the end of the first trimester, if not moving into the second trimester. At that point, all of the organs are developed. So if we were on a medication that we were not supposed to be on, if we were maybe partaking in some things that we shouldn't have been partaking in, the damage is done a lot of the times by the time we find out that we're pregnant. So lots of room for error there. Can also be caused by genetic things. So we do see like a familial kind of inherited pattern with some of these. They're very common, very prevalent in a lot of genetic syndromes. So you see that precious little Down syndrome nugget. CHD is very, very common with Down syndrome. And a couple other syndromes that I'll mention. And then we talked kind of about environmental factors. So maternal diseases, gestational diabetes, or just good old legitimate diabetes. Diabetic patients get pregnant. Anytime the fetal heart is subjected to hyperglycemia, very, very increased risk for congenital heart defects. And then other drugs, even not, illicit drugs, just pharmaceutical drugs. Sometimes it's a risk versus benefit situation where we have to determine, is it worth mom coming off this medication for 9 months, or do we risk potential fetal harm? Nothing's ever 100%, right? We don't live in a vacuum. And then infections as well, like measles, mumps, rubella. If mom gets certain infections while she's pregnant, it can cause congenital heart disease in the baby.
So do those environmental instances, do they have to happen in the first trimester or just anytime throughout the pregnancy?
So, good question. So the question was, do those environmental factors have to happen in the first trimester? So structurally, more so, yes. But we do have, so like example, a lot of antidepressants potentially can cause persistent pulmonary hypertension of the newborn. So that kind of falls under this as well. But, not necessarily like a structural defect as in like there's half the heart missing or something like that. So pathophysiologically, these are structural defects. The heart did not form, the way that it should. They're frequently diagnosed in utero. So on the big, around 20 weeks, mom will get, if she's getting adequate prenatal care, an anatomy scan where they look at a lot of details of all the things. And one of the things they're looking at, one of the big things they're looking at in that ultrasound is the fetal heart. Do we have all 4 chambers? Are all of the outflow tracts? So is there an outflow tract for the right ventricle? Is there somewhere for blood to exit the right ventricle? Same thing, left ventricle. They're looking at everything very detail oriented. And if anything flags as abnormal, they're going to refer mom to go see a high risk doctor, going to get more, higher level ultrasounds to see, okay, is this an actual defect that we're dealing with? What kind of defect are we dealing with? Do we need to deliver at a hospital that can take care of this baby, immediately? Because with certain defects, this baby's going to crash right after that placenta is clamped and cut. Just fact of the matter. And so, do we need to deliver somewhere else where we have, PEDS cards that can actually save this baby's life? But if not diagnosed in utero, they'll frequently become very distressed depending on the defect. Some can get very distressed, like I said, minutes after birth when mom's no longer oxygenating baby through the placenta. Or if it's one where the baby can kind of, shunt blood and compensate for a couple weeks, they might come back a couple weeks later with signs of heart failure. So we suspect congenital heart disease in any infant with cyanosis that does not improve with oxygen administration. Logically, if you give oxygen and it's a pulmonary problem, that should fix the problem. Not so with cardiac stuff all the time. So if you've got them on 100% oxygen and they are still just an Oompa Loompa, be thinking cardiac. And like I said earlier, tachypnea with no retractions, tachypnea for no good reason. It's probably the heart. When a baby's born, we do that initial newborn assessment. We'll frequently hear murmurs with these defects just because of turbulent blood flow. A lot of the times those murmurs are going to trigger an echocardiogram to be ordered just to rule out any kind of critical congenital heart defect. And then a lot of hospital policies now in the nursery before a baby, definitely before they're discharged from NICU, but also nursery. They do something called CCHD screening, which stands for Critical Congenital Heart Defect Screening. And I'll show you, there's a little algorithm, but basically they check the pulse ox in the right upper extremity because that is typically pre-ductal or pre-patent ductus pre-ductus arteriosus perfusion. And then they'll get a pulse ox on any of the other extremities because those are typically post-ductal. And if those saturations are, more than a couple points different from each other, that triggers an echo before that baby's discharged. And that's drastically reduced the amount of babies or the number of babies that are discharged with these critical defects that then go, are discharged home with a parent who thinks their newborn's perfectly healthy. And then we wind up, back in the hospital in a couple of weeks in fulminant heart failure because we missed a defect. So complications here, heart failure for obvious reasons, hypoxemia, we're going to talk about shunting. With some of these situations, we've literally got deoxygenated blood being shunted from the right side of the heart to the left side of the heart and then ejected to the systemic circulation. Completely, or mostly bypassing the lungs, not picking up any oxygen. Growth retardation, just very, very high metabolic demand that the body is not able to meet. Developmental delay. Brain can't develop the way it's supposed to, right? It's not being perfused adequately and getting adequate oxygen. Pulmonary vascular disease, we talked about that a little bit. We'll talk about it some more on the next couple slides. And then failure to thrive. So those babies that come in, after a couple of weeks, they're typically tiny and scrawny because, they'll eat for 10 minutes and take an ounce and then they're just exhausted and they can't do anymore. So, and then their metabolism is just absolutely wild. So that picture on the right, that's a heart baby. Like I said, this is a ped CVICU patient for sure. Got, 1, 2, 3, 4 chest tubes, intubated, all the things. So overall signs of congenital heart defects, typically tachycardic from trying to compensate. Typically tachypnic, also trying to compensate for that lack of oxygen. And then the lungs are frequently overly perfused, so that stresses them out. We talked about growth retardation, dyspnea, orthopnea, fatigue, and they'll get upper respiratory infections more frequently. And the reason for that is just because the blood flow is altered. And so if you think about our immunity is in our blood, right? So if the lungs are having altered blood flow through them, or, you're getting recirculation, or maybe, the lungs are more so being bypassed circulatory wise, then we're not getting as adequate immune protection. And so we can see pathogens take over a lot easier. So this is, you do not have to memorize this. Please, for the love of everything, don't memorize this. If you work nursery, you'll become familiar. This is just, kind of a standard example of that critical congenital heart defect screening. So they do, the pulse ox. They have to be over 24 hours of age. And then they get the different pulse oxes. If they're too different from each other, then you repeat it. You can repeat it twice if they fail it twice. Echo. And we give them chances just because there's lots of changes going on in the fetal heart immediately after birth, right? Hopefully, if you watch that video, you'll see it's a very complex, really cool process. But so not uncommon to hear a murmur and then a couple hours later, redo your assessment and you're like, okay, it's gone. Just because things are very fluid in the first couple of days as the PDA starts to close and that PFO starts to close as well. So types of congenital heart disease. When I was in school, it was like cyanotic versus acyanotic defects. We have kind of moved away from that just because, in all honesty, I will present these to you and teach them to you as like black and white, things shunt this way with this defect. But in reality, it's not always like that because a lot of these defects don't always exist in isolation. a lot of the times kids have multiple defects at once. And so they, a VSD might shunt this way in theory, but if they've got 2 or 3 different defects, it's really just going to depend what the pressures in their heart are at that moment in time. So, study it and remember it, the way that I present it to you. But terminologically, we've kind of moved away from cyanotic versus acyanotic because it's not always so. And so, like I said, there are a lot of these that we'll just kind of touch on. But for time-wise, I'm going to, harp on the ones that have asterisks. And so if you think about it more so increased pulmonary blood flow versus decreased pulmonary blood flow, like pathologically, it makes a little bit more sense. And then we'll go over a couple obstructed ones and then mixed blood flow as well. So increased pulmonary blood flow. So remember, after transition, so when I say transition, I mean like umbilical cord is clamped, cut, baby is now trying to transition to extrauterine life, do all the things on their own. Stressful. They don't always kill it. But remember, after transition, heart pressures are higher on the left side of the heart. So that's the systemic side. And blood is going to flow. With these defects, blood is going to flow from left to right. So oxygenated, quote unquote, to deoxygenated, causing over circulation to the lungs and right side of the heart. This is eventually going to lead to signs of right-sided heart failure, pulmonary hypertension. So we see lots of respiratory signs and symptoms with these kids. Tachypnea, respiratory infections, and signs of decreased systemic perfusion. So definitely tachycardia. We talked about murmurs. So this cute little guy says, I'm not blue, I'm not cyanotic, I'm just tired all the time. Because I'm still getting oxygenated blood out to the systemic circulation, but a lot of it's just being recirculated through the lungs. So first one, PDA. So this is a good thing in utero, right? We need this. In utero, we like this. But it's a problem if it doesn't close after birth. So with this one, the ductus arteriosus fails to close. It's more common. One of the more / most common defects, especially in preemies. Blood's going to flow from that high pressure aorta through the PDA, back into the pulmonary artery, recirculating to the lungs and the right side of the heart. The clinical presentation is going to depend on the size. If it's tiny, they might be asymptomatic. But with an impressive PDA, they might have a full or bounding pulse because of that kind of recirculation. And then those pulmonary signs of overcirculation, congestion, and distress. And I tried to list just the characteristic, like the different signs, just because a lot of them have the same signs, right? A lot of times they'll have a continuous machine-like murmur. And potentially a wide pulse pressure. Assessment and diagnosis are going to be pretty standard for all of these. It's going to depend on the history. They can get an echo to confirm. Might get an EKG or ECG. And then potentially, they might go for a heart cath if they need to. Our interventions here. We can give 2 different meds if we need to close it. If it's so big that it's causing problems, we want to close it. So we can give indomethacin to preemies or ibuprofen to infants and kids, adolescents, etc., to close that PDA. So from the video, fake bonus points to anyone who can tell me what triggered the PDA to close if you watched the video. What was it? So the changes in pressure, yes, but there's a substance that when the placenta is delivered, is no longer at play. Starts with a P. Prostaglandins. Good job, Marley. Prostaglandins. So we had the withdrawal of prostaglandins when the placenta was delivered and the umbilical cord was clamped and cut. So these meds work because they inhibit prostaglandin synthesis. So continued prostaglandin exposure will keep the PDA open. Taking away the prostaglandins will close it.
That's endomethacin and ibuprofen?
Yes.
Okay.
Just think back to farm. Why do we give ibuprofen? The prostaglandins are one of the things that stimulate the pain receptors. That's why ibuprofen helps. So that'll close it if we need to. We can also, there's surgical procedures. They can ligate it where they literally tie it off. They can go in, the cath lab, place bands or coils to occlude it. Typically, we see a good prognosis if it's treated before right-sided heart failure and pulmonary hypertension develop. But if not, we can see those as complications. All right, ASD stands for atrial septal defect. This is an abnormal opening between the right and left atrium. So in that video, it talked about the PFO, the patent foramen ovale. PFO is essentially an ASD that should close. Sometimes it remains open, but there are other ASDs that can occur as well. So the higher pressure on the left side of the heart, blood's always going to flow from high to low, right? It's going to flow from higher pressure to lower pressure. That's just the path of least resistance. So it causes right heart and pulmonary overcirculation again. Again, the symptoms depend on the size. A lot of the times these are just found kind of accidentally when we hear a murmur and get an echo. We're like, oh, you have ASD, cool. But if it's big enough to, make problems, it'll be those typical signs that we talked about. Standard assessment and diagnosis. The history is going to be, pretty important. Interventions. Some will close spontaneously. Other large ones might require a patch if they're worried about heart failure starting to develop. And if it does, then we manage that medically. They can go in the cath lab and place a patch or some kind of occluding device. You might see these kiddos be on some kind of anticoagulant or a blood thinner. Just because what do we fear happens when we have blood recirculating? Clotting, right? Recirculated blood is typically more stagnant, right? We want blood to constantly be flowing. And so if it gets over-circulated, we can see a higher incidence of clots. And if we get a clot in that right atrium that goes to the right ventricle, that's a PE situation, right? We don't want that. We can also see dysrhythmias for the same reason we talked about, right? So we've got a whole lot more blood coming from left atrium back to right atrium. That right atrium is eventually going to get stretched out, right? So we can see some right atrial arrhythmias start to develop. And then eventually the right ventricle will follow suit and we can see arrhythmias start from there as well. And then PAH is pulmonary artery hypertension. Just because we've got, with any of these, we have a fear of pulmonary artery hypertension. Because if we've got over-circulation of blood to the right side, that's a whole lot more blood that the pulmonary artery is in turn going to have to accept. And it wasn't made for all of that. The pulmonary vasculature is very delicate. Very delicate. And so when we have all that extra blood, it's going to eventually start to damage the pulmonary artery and it becomes a lot more thick and almost like fibrotic and sclerosed almost. And so then we've got pulmonary artery hypertension. That artery is very, vasoconstricted and blood can't flow through it. And so then that becomes a very hairy situation because that's not necessarily something we can reverse. So I've linked, like I said, the little osmosis videos. For time, we won't watch them, but feel free to do so. No, I don't want you to play it. Thank you. Okay. VSD. So ventricular septal defect. Essentially the ventricular version of an ASD. So it's an abnormal opening between the right and left ventricle. We still have left to right shunting because still higher pressure on the left side. Blood flows from high to low. Again, presentation depends on the size. We can see increased pulmonary vascular markings with these. And basically, that just means you're able to see the pulmonary vasculature on a chest x-ray much more prominent than you normally can, just because there's a lot of blood, a lot more blood flow to those vessels. Everything's a lot more congested with blood, so you can see them a lot greater, which you would think would be a good thing, but it's actually not. Interventions, again, heart failure management, right? So these kiddos might be on DIG, diuretics, ACE inhibitors, banding. So when I say banding, I mean pulmonary artery banding. So that's something that they can do. Well, they'll go and place, just think like a small rubber band around the base of the pulmonary artery. And that's a protective mechanism. It limits the amount of blood that the pulmonary artery is going to accept. And so it helps protect against pulmonary artery hypertension. It's a pretty common thing they'll do. They might place a patch for a small, or, a moderate to large one, but a small VSD, we might watch and see. So a lot of the times they'll grow out of it, but ultimately might need surgery.
So it can heal on its own like this.
Complications can have aortic valve regurgitation, and these kiddos will be, these are one of the ones that are increased risk for infective endocarditis, just because all of that turbulent flow right there by those valves. And then again, heart failure, pulmonary artery hypertension. Okay, switching gear a little bit to the defects with decreased pulmonary blood flow. So we were going left to right, oxygenated to deoxygenated, pulmonary overcirculation. So now we're going the opposite way. With these, we have some obstruction to blood flow from the right ventricle out to the lungs. So we've got high right-sided heart pressures. So that makes us shunt, the blood shunt the opposite way. So with this, we're going to go from now right to left, deoxygenated to oxygenated, quote unquote. Or deoxygenated to systemic is probably a better way to think about it. So these are the ones our patient's going to be cyanotic because we are pumping deoxygenated blood out to the systemic circulation. One of the things our bone marrow is going to do, because the body thinks that like we're constantly hypoxemic, right? So the body, what does it tell the kidneys to do? I'm anemic. Put out erythropoietin. So the kidneys put out erythropoietin. Erythropoietin tells the bone marrow, hey, make more red blood cells. We need more oxygen carrying capacity. So it does. But that makes my blood very thick, right? I've got a whole lot of red blood cells in the same volume. So what do you think that predisposes my patient to?
Lots of clothes.
I love that you said polycythemia. Yes, the term is polycythemia, and yes, blood clots. Thromboembolic events. I don't love that. With these, we'll see what we call TET spells, T-E-T, or hypercyanotic spells. We'll talk about them specifically with tetralogy of Fallot, but really you can see them with any of the cyanotic defects. And these are events. These TET spells are caused by any stimuli that decreases systemic vascular resistance. So think playing out in the heat. Think taking a hot bath. Think exercising. Think fever.
You said that decreases what?
Systemic vascular resistance. So that increases my right to left shunting because we flow from high to low, right? So if my low just went lower, then it's just a free flow. Free flow from right side of the heart to the systemic circulation. So this will lead to profound cyanosis, severe respiratory distress. They'll start to panic because they're very, very, very oxygen hungry. They'll lose consciousness and collapse, and they can even die from this if we don't intervene. Actually, I can remember in first grade, there was a little girl in my class who had HLHS, so hypoplastic left heart syndrome. And we were on a field trip playing outside one day, and I didn't realize it at the time. But now thinking back, she got very, very, very symptomatic, like puked, passed out, all the things, because we were outside playing. It was at the end of the year, so it was like May, she got too hot, and so she started, shunting. She had a TED spell. So yeah, kind of weird, kind of cool. But yes, so we'll talk about the squatting. They get very cyanotic. We'll see clubbing just because of the chronic hypoxemia, right? And then the syncope from the lack of oxygen.
So even that young, they'll start clubbing.
Mm-hmm. All right, pulmonary stenosis. So with this, blood flow from the right ventricle is decreased due to a stiff pulmonic valve. Symptoms depend on severity as usual, but we will typically hear a systolic murmur just because of that turbulent blood flow. We want to prevent infective endocarditis. They can go in the cath lab, do a balloon valvuloplasty where they kind of, insert the catheter and blow up that little balloon and break up the stenotic valve. Bless you. Or they can go in, surgically and open up that valve if we need to, or replace the whole thing if it's just trash. And then, of course, we want to manage heart failure. And then our typical complications. All right. So I'm going to talk about tricuspid atresia. There's also a thing as pulmonary atresia. It's typically not as severe, but the treatment is similar. So stenosis versus atresia. Stenosis is narrowing, right? Atresia, I remember atresia in my head, like, atresia. So that's why I've got the little, little picture right there, because atresia is not good. Atresia is, there needs to be an opening there, and there's not. So atresia is typically a medical emergency situation. It's a panic sphincter tightening situation. So with tricuspid atresia, there is no valve between the right atrium and the right ventricle. So I really need to have a couple other defects, hopefully, right, for things to circulate at least a little bit the way that they're supposed to.
So this is one of those ones where you'd want to deliver at a hospital that can.
Oh, yeah. Oh, yeah. Yeah, this is when they see on a fetal echo and they're like, yeah, do not pass go, do not collect $200.
So it's kind of the opposite of that first thing. Instead of getting rid of the prostaglandins to close it, you're going to want to add them to open it.
Look at you, truly.
Kind of all
Yes.
right.
This is what we call ductal dependent. This is a ductal dependent defect. So yes, I need abnormal openings, right? If I don't have any other, like an ASV, or if the PDA doesn't remain open, I've got no way for blood to get from one side to the other side, and my patient's going to die, just fact of the matter. So yes, this is a ductal dependent. One of the things we'll do for that is we will give prostaglandin infusions. Your major side effect with that is apnea. If you are going to infuse prostaglandins, you better be ready for your patient to stop breathing.
Smallly.
I know, perfect, right? Love that for me. But it's real, it's the truth.
Just stand over the tube.
Yeah, have the airway card ready.
Go ahead and get RT on speed dial.
So typically, there's an ASD or a PFO, and the PDA, or maybe a VSD, just so we have some kind of circulation that's able to go through.
If there isn't another route, does your heart just not beat?
So we'll be okay. Because the PDA, I mean, we're gonna have a PDA, right? Unless this is just a very severely syndromic situation, and a lot of times those are gonna be like your first trimester miscarriages, or we're gonna lose the baby before we get to this point.
Okay.
Right, yeah, like we're just not compatible with life at that point. But most of the time we've got a PDA and a PDA and a PFO initially, at least. And then we just gotta figure out what's going on before those things start to close.
But sometimes there's like a miracle that even got this far.
Right.
Yeah.
A lot of these defects, I'm like, goodness.
Yeah.
Thank God for a PDA. Okay. So yes, frequently the right ventricle is very wimpy, because it hasn't been used at all, right? There's really very little blood flow to it. So typically that right ventricle is very underdeveloped, and the right atrium will become very dilated. So we watch for arrhythmias there. We'll need long-term antibiotic prophylaxis, possibly anticoagulation, but our mainstay here is prostaglandin. We'll manage heart failure medically with all the things we've talked about. This is very much a surgical situation. And again, we can also have pulmonary atresia, but it's typically not as severe, because we've at least got a tricuspid valve in that situation. All right, TOF, tetralogy of Fallot. So tetra means 4. She says so confidently 3. No, 4. Tetralogy of Fallot. So 4 different defects. I know this kiddo won the jackpot, right? So first we have pulmonic stenosis. That's going to lead to right ventricular hypertrophy. So back pressure from the pulmonic valve causes the right ventricle to beef up. We also have a VSD. So then we've got a high pressure right side of the heart situation and an opening between the ventricles, so blood flows from the right side to the left side. And then we've also got what's called an overriding aorta. So it's not super clear in this. You'd almost have to look like side by side, but in this picture you can kind of see the aorta is situated more so to the left than normal. So the aorta kind of sits over, almost like half and half over both ventricles. So what that translates to is it's going to accept blood from both of them, right? Especially in light of the fact that we've got that VSD there. So that translates to we've got mixed blood being pumped out to the systemic circulation, right? You can see we've got blue blood, which is not an actual thing, but just for pictorial representation. Blue blood, red blood mixed together makes the pinky purple blood, and that's what's being ejected out into the systemic circulation.
It's a whole lot of mixture.
It is a whole lot of mixture, more so than normal because of the way that aorta is situated. So really, our shunting and how severe this condition is going to depend on 2 things. The degree of pulmonary stenosis, because that's going to increase our right side of pressures, and then the size of that VSD. This is when we definitely want to catch in utero on ultrasound. presentation. Very harsh, very loud murmurs because of all the things. You just don't even know what way blood is flowing and shunting in this situation. It's just all over the place. Very loud. And their heart will frequently look boot-shaped on an x-ray. Just because of the different, aortic anatomy, and they've likely got some ventricular hypertrophy at birth. So let's talk about TET spells, hypercyanotic spells. So we said, those were things triggered by things that decrease our systemic vascular resistance. So when this starts to happen, toddlers will want to squat. You'll see them do the little picture said cyanotic squat, right? So they'll squat, and that increases their systemic vascular resistance. It increases the amount of blood that's being returned to their heart, so it augments their preload and increases their afterload. And so that gets more blood back to their heart to hopefully be oxygenated, and then hopefully gets them shunting blood from left side to right side, and hopefully that blood will go to the lungs to be oxygenated. So if you ever see a TOF kid squatting, we don't love that. But really, the shunting might depend on which circulation, pulmonary versus systemic, has the greater pressure. So if we think about a kiddo that's crying, we've got more pressure in the pulmonary circulation, right? So with that, blood's going to flow from deoxygenated to systemic. We're going to see more profound cyanosis there. We want to increase their systemic circulation by, if they're older, they can squat. If they're a baby, we can do like kind of knee to chest position to accomplish the same goal. Other interventions. Keep them relaxed and calm. Give them oxygen. So whatever blood is able to make it to the lungs, we want to max out the oxygen carrying capacity of it. And we can also give them morphine that helps to relax them. It also relaxes the pulmonary vasculature, and so decreases the pressure on that side of the system. Typically, if we have a TOF kid, as soon as they start having TET spells, that's usually a pretty good sign that they need to go ahead and proceed with surgical repair at that point. And then this is just another little picture. You can see the boot-shaped part. All right, aortic stenosis. This is narrowing of the aortic valve. Impairs blood to the systemic circulation. Decreases peripheral circulation and causes blood and pressure to build up in the left side of the heart, and then eventually it'll start backing up into the lungs. This also means that the actual heart muscle might not be perfused as adequately as it should, right? Because remember, the heart needs blood flow as well via the coronary arteries. So normally blood flows through that aortic valve, and then almost immediately perfuses the coronary arteries, which deliver oxygen and nutrients to the heart muscle. And so if that process is not occurring as well as it should be, then we can see the patient have chest pain. And, signs of a heart attack, right? Because essentially what's happening. Syncope, exercise intolerance, and unfortunately sudden cardiac death. If the heart muscle the perfusion is so poor, we can see their heart just stop. We can repair this surgically, either with a valvuloplasty or, maybe a replacement. We want to prevent bacterial endocarditis, prevent heart failure. And we can see pulmonary vascular disease as a complication of this because of all of that backflow of blood and back pressure. Just the mnemonic. All right, coarc. This is a narrowing of the aorta. Can occur in different places, but it's typically, at like posterior to the aortic arch, somewhere on the, descending aorta. So if I clamp off my aorta, what's not being perfused?
Everything.
The body.
Yeah.
Yes. So I worry about distal perfusion here. So I'm going to have higher pressure in my upper extremities because those 3 large vessels that branch off the aorta right there, that's like, subclavian artery, all those things, perfuses the upper half of my body, but then the lower half is perfused further down. So I worry about distal perfusion.
So that's gonna be like pedal pulses and
Right,
capillary fill and all
Right, pulses won't be great, pedal pulses won't be great, capillary fill, but also think like gut perfusion,
that.
kidney perfusion, liver perfusion, all of those things are typically, further down.
So like, this might sound weird, but like, could the thing just eventually pop because the pressure is building up on one side so much?
Oh, you can definitely have aneurysms. For sure. So especially, the question was, like, can we have issues with all the back pressure? And definitely, we can see elevated blood pressures in the upper extremities when we compare them to the blood pressures in the lower extremities. This is another thing frequently that we'll do before discharge on NICU babies is get 4 extremity blood pressures. And if they're different, typically more than like 10 points different, that's a no-no. That's potentially, we've got a potential coarc situation going on. Upper extremity pulses will typically be bounding because there's so much more volume, more pressure, right? And then other symptoms, they might be dizzy just because there's so much blood volume going to the head. You can have syncope, headache, nosebleeds. There's just so much volume, so much pressure to the upper part of the body. And eventual heart failure. So we talked about decreased blood pressure in the lower extremities. The pulses are going to be poor. Skin probably be cool in those lower extremities, just because general lack of circulation, right? Older kiddos might complain of claudication. Remember what that was? Right. So like the calf pain when they're trying to exercise or walking around because of the lack of oxygenation, lack of blood flow. So in severe cases, we'll maintain that PDA, make sure we've got some kind of circulation go into the lower extremities. Manage heart failure, but ultimately it'll likely need surgical repair. We do see a incidence of recurrence after surgery. We talked about heart failure, renal failure. NEC is neck, necrotizing enterocolitis, so basically lack of blood flow and perfusion to the bowels, and they can start to die. Stroke, aneurysm formation, and if that bursts, have a ruptured aneurysm. All right. I think for time's sake, I'm gonna skip TGA. Cool with that? I know, we're so upset. And Trunkus, because I want to make sure we've got time for the others. Those two are pretty rare.
Is it testable though?
No, it's not testable.
Okay.
I will not
Just making
test
sure.
you on what I don't lecture. And then this is just another little mnemonic to help you. All right. Cardiomyopathy. Etiology here. A couple different ones. Can be infectious, widespread generalized inflammation, autoimmune in nature, chemo, congenital, genetic factors, whatever the cause. Our patho here is the heart muscle is diseased, basically. Whether it's the ventricle is abnormal in size, it's abnormal in thickness, or abnormal in its contractile function, it is abnormal. There are multiple different types. We can have dilated cardiomyopathy. You can see the top right picture, very thin. You know, the ventricle is very thin and pitiful looking. We can also have hypertrophic, so bottom left of that picture, the opposite of dilated. There's a lot of muscle there, which you would think would be a good thing, but it's really not, because it decreases the filling capacity of the ventricle, right? And if you've got very thick muscles, so think of the bodybuilder that's like, his biceps are so big, and he grabs a fork and gets some food off of his plate, and he's trying to bring his fork to his mouth, but his biceps are so big. When he flexes, he can't get the fork to his mouth. That's how this is. Like, the muscle is so thick and hypertrophied that it can actually block the outflow of blood out of the ventricle. So it's really just good for nothing, right? Think of it that way. It's good for nothing. What are you good for? Absolutely nothing. Hypertrophic, absolutely nothing. So dilated and hypertrophic are the most common in kids. And with dilated, that ventricle is thin and really stretchy, like an overused rubber band or a balloon that you blew up and deflated one too many times. The contractile strength is super weak.
So it only affects the ventricles?
Typically, yes.
Okay.
So our assessment, we're going to have signs of heart failure, of course, right? We can see sudden cardiac death and hypertrophic cardiomyopathy. It actually happened to a guy I went to high school with. He went to bed one night and his parents woke up and he had died in his sleep. So of course they did an autopsy and his heart was massive. He had congenital cardiomyopathy.
So did that not like, did he ever have any signs and symptoms?
Nope. Very common with hypertrophic cardiomyopathy.
Just never have any symptoms?
Yeah, it's just one of the things you don't know till you know. Yep,
That's
I know, new
terrifying.
fear unlocked, right?
Yeah.
When you were born,
Yeah, I mean, like, his heart looked normal, and then, like, over time,
Mhm.
it just.
Oh, that makes sense.
Yeah, and very common with like high school athletes. And so he played baseball, football, loved energy drinks. So that's what he had played ultimate frisbee that afternoon or evening. So very common, unfortunately. All right, let's see where we're at. So family history will be important because there's very much a genetic thing here. We'll get an echo, EKG, all the labs we talked about.
So like with history, would you want to know if they've done like steroids in the past?
Yeah, that would be,
Batteries?
yeah,
How many
stimulants,
energy
any of the
drinks do you
things. Interventions, manage heart failure medically. This is a patient that probably would be a candidate for an ICD, so stands for internal cardiac defibrillator. So it will abort any fatal arrhythmias if they occur, and they frequently do. Also maybe a pacemaker, probably be a transplant, or, you know, an assist device candidate. But ultimately you might need it. Oh yeah, sorry, I mentioned transplant. And then all the complications that we talked about. And I've got two videos linked for you. One is dilated, one's hypertrophic.
So there's really nothing you can do to fix it.
Nope.
It's just there.
Nothing you can do to fix it. Just hopefully prevent it from getting worse and killing you. Sorry, not to be
That's okay.
blunt. I mean, it is what it is.
Yeah.
So just to differentiate some terminology here, cardiomyopathy is very specific. That's a specific term. This is a specific disease of the heart muscle. You know, we talked about it. Can cause cardiomegaly. So cardiomegaly is your heart is just massive, right? Like look at the heart on this x-ray. Holy cow. Typically general rule of thumb is you don't want the heart to take up like more than the chest on an x-ray. This is just stupid how big this heart is. And you can kind of see like the increased white little streaky things. That's like increased pulmonary vascular markings. So cardiomegaly is more general, just means an enlarged heart. Definitely a clinical manifestation of cardiomyopathy, but can be caused by a lot of other things as well.
I think it's huge.
Right. And then just a funny, the Grinch's heart grew 3 sizes that day, and he promptly died of cardiomegaly. All right, acute rheumatic fever. So this is an autoimmune condition against group A strep bacteria. So yeah, not to just give you signs of gross pictures. I do love to do that. But yes, so impetigo, think strep throat. Yeah, those lovely tonsils. So that autoimmune reaction causes inflammation and damage to the connective tissue in the heart, especially the mitral valve. Also damages connective tissue in the blood vessels, brain, skin, and joints. Typically arises 2 to 4 weeks after an untreated strep infection. And per the CDC, it's on the rise in 2022. So if you didn't have enough to worry about, you can add rheumatic fever to the list. Along with plague, monkeypox, all the fun things. Yes. So our presentation, it can be kind of subtle or overt. Really just depends. They'll typically have fever, that general malaise, and a previous sore throat, or, you know, just lovely impetigo. Can have joint swelling, joint stiffness, maybe a rash. Pancarditis. So carditis meaning inflammation of the cardiac muscle. Pan meaning all of the heart things. So like endocarditis, myocarditis, pericarditis, all the itises. Pan means
So
all cardiacitis, yes. All the itises.
Sounds
Some specific diagnostic criteria are the Jones criteria. I have pictures to help you with that, and there's a table in your book. Our best intervention is prevention. Want to make sure strep infections are treated adequately and completely.
Now I'm learning how much I actually usually like treat. Because I just roll dog.
Right. Everybody's like, oh, strep is fine. No, just
Strep.
kidding. It can cause rheumatic fever.
If you have strep, I just let that fever run it out and I'm good.
So with the carditis, you know, potentially a murmur, cardiomegaly, you might appreciate a friction rub on auscultation. Might see arrhythmias, our beloved signs of heart failure, emboli. We'll see those being kind of thrown throughout the body. chorea, which is like some involuntary muscle movements, and that's a signal that the central nervous system is being affected by this. Erythema marginatum is kind of the characteristic rash that goes with this. And these are all in that the Jones criteria. I know y'all are writing frantically, but they are found places. So ESR, CRP will be elevated because of inflammation. Probably have some EKG changes because the heart's mad. Cardiac enzymes probably be elevated. Probably have a positive strep culture. Maybe, maybe not. If it's been partially treated, that might come back negative. But we should have an elevated ASO titer, which stands for anti-streptolysin O. And it's a positive titer, meaning the body has been exposed to strep recently. Chest x-ray, echo. So again, best way to treat is to prevent. But we will see anti-inflammatories given. So naproxen, ibuprofen. They'll typically be given antibiotics to adequately treat the condition. And they might need prophylactic antibiotics until like 20s, 30s. Especially if there was valve involvement. And we'll support the heart with heart failure interventions. So here's that erythema marginatum, the top left. And then the bottom two pictures are different little nodules, subcutaneous nodules. And so that's just the reaction, like subcutaneous reaction within the connective tissue.
Poor baby's fingers.
I know. What fingers? Sorry, the picture quality is not great. But then just a little mnemonic to help you. And another one, because I just love these pictures. All right, Kawasaki's. So I told you with infection immune, we talk about IVIG again, and here we are as promised. So this is an idiopathic, meaning we don't know really what causes it. Autoimmune condition that basically causes widespread blood vessel inflammation. But a lot of inflammation within the blood vessels of the heart can also affect the mucous membranes and the lymph nodes. It is the most common cause of acquired heart disease in kids. We see this pretty frequently, especially in males, those of Asian and Pacific Islander descent, and typically affects 5-year-olds and younger. We do see a potential genetic influence, and there's typically some kind of infectious trigger, typically viral, of this inflammation. And basically the immune system kind of just goes haywire, mounts this very inappropriate, severe inflammatory immune response against this and starts attacking its own blood vessels. Yeah. So it causes widespread vasculitis. And that's going to lead to platelet aggregation within those vessels and potential thrombi to form. We also worry about aneurysms. Remember, connective, the middle layers of the blood vessels, if that gets attacked, then we've got weakened vasculature, and that can lead to the outpouching of aneurysm formation. And we worry most about coronary artery aneurysms. So our presentation, typically acute symptoms are going to be very high fever, like high, and they're prolonged. So think like 5+ days, unresponsive to meds. This is the parent that's told you, I've been doing Tylenol and ibuprofen around the clock. Nothing will break this kid's fever. History of some viral upper respiratory infection symptoms, probably some beloved nausea, vomiting, diarrhea. joint pain, weakness, lymphadenopathy, typically cervical, unilateral. And I've got pictures of all these on the next slide, so you don't have to write so frantically. Conjunctival erythema, so reddened conjunctiva, but no exudate. So remember pink eye, there was all that yummy crust. There's no crust with this. I say yummy with all the sarcasm. They might have a rash on their trunk or around their perineum. Their hands and feet will get very swollen. Their lips can get very dry and cracked. Their tongue gets swollen, and I don't want to say blistered, but it almost takes on the look of a strawberry. It gets very swollen and gets kind of like petechiae on it. That's very hallmark of Kawasaki's. And then they'll also have all those signs of myocarditis. So potentially an effusion, friction rub, heart failure signs, all those things. So then subacute, typically the fever subsides, but this is when, the coronary aneurysms can occur and it can lead to a heart attack or sudden cardiac death. That's our big worry here. And during this phase, the palms and the soles of the feet actually desquamate, so meaning like the skin kind of like starts to peel off of them. This is actually something that we saw with COVID as well. I remember when I got COVID the first time, I had like a rash and my hands and my feet really hurt. And then a couple days later, like my skin started peeling off of my feet and my hands. And I'm just like, do I have Kawasaki's disease? And it was actually funny because then what we saw was kids didn't really get affected by COVID, but 4 to 6 weeks later, we saw them start coming in with this condition that looked very, very, very close to Kawasaki's called MISC. And so clinically, it was very, very similar. So viruses are just wild. MISC, so multi-system inflammatory syndrome in children.
Got it.
Just that's a
I thought it
Yeah.
was just
that's a neither here nor there. So they're also going to have a very high thrombocytosis, and then it resolves. So our assessment and diagnosis, history and presentation is going to be very, very big here. Lab results, CRP, ESR are going to be elevated. White blood cell counts typically elevated as well as our platelets. And like very elevated. I'm talking like, 600, 700,000. They'll get an EKG and an echo. Echo is huge, huge, huge to check for those aneurysms. Interventions. This is typically a PICU patient if they have to be admitted for this. We're going to do fluids because they come in pretty dehydrated. IVIG is a mainstay, and we want to try to get that in the first 7 days from symptom onset for it to be most effective. Aspirin, and not just aspirin, high dose aspirin. I'm talking you're pulling 10 tablets of aspirin.
Oh, God.
Yes.
what?
Yes. But risk versus benefit, right? Our worry is Ray's syndrome. This patient's already in the hospital. So we're monitoring for that. They're in the best place that they could be if they start to, manifest some symptoms of Ray's syndrome, and we'll support them, of course, if they start with that. But the worry of the coronary artery aneurysm and the sudden death from that is a much greater worry than Ray's syndrome. Possibly steroids, possibly antibiotics. So we want to make sure we educate on the signs of aspirin toxicity, monitor for bleeding, monitor all of our labs. Typically, they need to take it easy for a while. This usually hits them pretty hard, kind of like mono almost. They're not themselves for, upwards of 4 to 6 weeks. Remember, we talked no live virus vaccines for 12 to 15 months after IVIG. definitely need a cards follow-up. They typically get echoes subsequently after this to monitor if they have aneurysms, to make sure that they're not further developing, or if they don't have aneurysms, that they don't develop them. And so here's just some pictures of the signs and symptoms. Oh, the little mnemonic crash. Make sure you see that at the bottom. It's a helpful way to remember it. And then same thing here. A little mnemonic with the Kawasaki's. I love these little pictures. And then you've got your osmosis video at the bottom. And then your salicylate. So aspirin is a salicylate, right?
Yeah.
That's equivalent to each other. So just review there. And I'm out of time. So I will not test you on infective endocarditis. But just, of course, make sure, know it's a thing. Infection of the valves. And it's very, very common as a complication with most of the conditions that we discussed today. Thank you for your time and attention. Happy Monday. Don't hesitate to reach out if you have questions.